bachelor's degree. He worked for Kaplan and taught MCAT courses and was a research assistant uh, the in Van Wickel's environmental toxicology lab at UC Davis. He completed his doctorate in osteopathic medicine at Nova Southern University in Fort Lauderdale, Florida. I went on to do his residency in pediatrics at Good Samaritan's University Hospital, and was a chief resident at the ICANN School of Medicine in Mount Sinai in Elmhurst Hospital. After residency, Dr. Uppal decided to pursue a fellowship in pediatric emergency medicine, and his professional interests are medical education, simulation, disaster medicine, and medical trainees wellness. You're welcome, and take it away.
All right. So welcome, everyone. Thank you, Jubin, for the introduction. So I know this is geared towards like pre-med. I actually had a lot of like similar support and mentorship. I remember when I was going through undergrad and part of Jubin and like the pre-health conference and these type of pre-med organizations. I think they were invaluable in guiding me and getting me mentorship and support and resources to pursue my goals. So this is my attempt to try to give back and see how I can help guide other people on their journeys. I can help with, any, general advice about is medicine. The first thing I think in undergrad is really figuring out, is medicine my path? Right? It's a long path. I know it scares a lot of people. It's medical school residency and things like that. But healthcare, there's many other allied careers and other things. And it's really discovering which path is the right one for me with your goals and your ambitions and the time commitment and financial commitments that you have to make. And once you kind of solidify that interest, really then honing and finding the resources and mentorship to really pursue it. So I encourage you guys first to just really do some soul searching and kind of figure out what you guys want to do. And I think that's what it took for me. And then I took a gap year and I really recommended it to everyone around me because it really helped me like focus and really solidify that this is the path I wanted to go. And then as you go on and you work your way through medical school, you figure out what specialty you want. And then in my specialty, I realized I wanted to do a fellowship because I really liked the pediatric ER, and I kind of went from there. My journey was maybe a little bit different in that I'm Canadian, so I had to navigate with some of the requirements of being an international student and needing a student visa and visa sponsorships and things like that. So if anybody has any questions regarding those type of things, I'd be able to kind of help out on that aspect. So I'll talk just a little bit about osteopathic medicine and then pediatrics and then PDM, and then I'll open it up to questions. So in undergrad, it was a little bit of a rough transition for me when I moved from high school to undergrad, and I didn't have the greatest GPA my first year and a half of undergrad, really trying to go from like, I guess, a non-competitive high school or something like that and figuring out the rigors of being at UC Davis, which was, pretty competitive and pretty challenging, and learning how to study and really focusing my efforts. So when I was looking to apply to medical schools, I had a very upward trend in my GPA and I had done pretty well in the MCAT, but I had to be realistic about my chances about, getting into med school, especially being an international student. So for me, that's really when I discovered osteopathic medicine. When I spoke to mentors, they said, hey, did you look into DO schools and MD schools and things like that? So I applied to both. There's a small subset of people who really love osteopathic medicine and are all gung-ho and are only applying osteopathic medicine. But I would say, like, the honest truth from being in an osteopathic school, the vast majority of us wanted to be a physician. and going to a DO school afforded us the opportunity to go there. There's a lot of DO schools now. There's a lot more than when I started. And really, you have to vet and see which schools have a good track record of getting people into the residencies that they want, have good clinical rotations, have a solid infrastructure and curriculum. And a lot of that is through networking or, finding online and, anecdotal type of things. So I chose to go to Nova because it was an established university. They have a big undergrad campus, multiple professional schools, a dental school, pharmacy school, nursing school, PA school, all that. And they have a teaching hospital that they're affiliated with, Broward General Hospital, which is like the biggest hospital in the Fort Lauderdale area. And it's a tertiary care level 1 trauma center, and you get to do your rotations there and things like that. So it afforded me all the opportunities that I needed. Some DO schools, they may be more community hospital oriented rotations. You might be going to little rural areas and things like that, which has its own benefits. You get maybe more autonomy and things like that, but you're not going to be in an academic hospital with residents and things like that. And probably not as much research opportunities. So if you're looking more towards primary care fields, it might be beneficial. But if you're looking to go to a subspecialty or a surgical field or a more competitive field, they may put you at a disadvantage. So those are all things that you want to really factor in when you're trying to figure out like that MD versus DO route, which school gets you towards where you want to go. And I know especially now there's different tracks you can find in your school, whether you go to MD or D school, you want to go on a primary care track and they get you into those type of rotations and things like that. So really figuring that out. So that was kind of how I chose like MD versus DO. Once I was in medical school, I didn't really know I wanted to do pediatrics until my 3rd year when I was on my clinical rotations, and I did pediatrics and I enjoyed going into work every day and it was fun and things like that. Whereas adult medicine made me a little jaded and sad and things like that, where peds, you have sad cases and things like that, but it was really fun and fulfilling. I kept trying to tell myself I don't want to do it because I don't want to deal with the parents, but in the end, I enjoyed it so much that, dealing with the parents and understanding where the parents are coming from and really, was worth it for me and it was fine. In residency is kind of when I figured I wanted to do pediatric ER. We rotate, through our pediatric ER as part of our general pediatrics training, and the fast pace of a ER and you never know what's going to come in, and dealing with critical care and things like that is something I really thrived in and excelled in and really enjoyed. So I was between pediatric critical care and pediatric emergency medicine. And I like the pace of pediatric emergency medicine more. And so, I chose that in order to make myself more competitive, because pediatric ER is one of the more competitive pediatric subspecialties. I did a chief year, so I did a 4th year of pediatric residency at Mount Sinai to just make myself a more competitive applicant. And from there, I'm currently in my 2nd year of 3 years of fellowship, and I plan on coming back to California after all this is done. Do you guys have any specific questions or anything you guys wanted me to comment on? You guys can type in the Q&A section.
How did you make up for your bad grades?
So part of it was I retook some courses that I did bad in. I think I spoke with you actually. Juban was like, hey, these grades, they're not going to get you in. He had a very frank discussion with me, which is you need somebody that's not going to lie to you and just say, hey, everything is great. And you have them having them read your personal statement and they're saying it's perfect. You need somebody who can give you honest, critical feedback, who's not afraid to sugarcoat it. So you know exactly where you stand. So I, retook some courses. I did a summer session at Davis. I did more upper division science classes. I took extra classes that were challenging and did well in them to show I had an upward trend. And I talked about it in my personal statement, like, hey, I had a rough transition, but if you you look at the last 2 years, 2.5 years of my undergraduate performance in upper division competitive science classes, I was getting all A's and, some B's and things like that, but showed a really upward trend, which was really helpful. And then in terms of DO schools, when they calculate your GPA, if you retake a course, they'll take the retake, or at least it did when I had applied, it would replace your old course. Whereas MD schools, when they calculate your GPA, it's an average. So if you got a C and then you got an A, it would average to a B for an MD school, whereas for the DO school, they would kind of take out the C if you got the A on your retake. So that helped my GPA when it calculated for DO schools. The other thing, the MCAT, was the great equalizer for me. I knew I had to do really well on that to show that I do have what it takes to be able to study a vast amount of material and score well on a standardized test. Because in medical school, we have all these licensing exams, the USMLEs and COMLEX, and there's 3 levels to it. And then when you go into residency, you have, after residency, you have board exams, which are very competitive and very difficult. So you need to be able to show an aptitude for taking and doing well on these standardized tests. So schools know that, hey, this person isn't going to have trouble passing the boards. And for residencies, they want to know you did well on your, USMLEs and things like that. So they know that you're going to be board certified when you graduate from there, and they're not going to have a high failure rate. Yeah.
First question is advantage of doing a PEDS versus EM residency if your goal is to do PEDS EM.
Yeah. So there's differences. So you can do PEDS EM either by doing emergency medicine residency first and then doing PEDS EM fellowship, or you can do PEDS first. The vast majority of PEDS EM fellows are pediatrics trained. I would say about 90% and above of PEDS EM trainees are pediatrics trained. There actually is advantage to being EM trained, I would say. So if you're emergency medicine trained, most EM programs now are 3 years, and the PEDS EM fellowship, if you're ER trained, is only 2 years long, because I'm under the American Board of Pediatrics, and they require 1 year of every PEDS fellowship to have research. So a year of my 3 years of fellowship, broken up longitudinally over 3 years, is research. Whereas the American College of Emergency Physicians does not have a research requirement for their fellowships. So you shave a year off of your fellowship. So you save a year. The other advantage is if you're board certified in both emergency medicine and pediatric emergency medicine, when you're looking for employment, if you wanted to work at a community hospital or a hospital that does not have a dedicated pediatric ER, then you could work as an adult ER or a regular ER attending there. And then do some, and just have the advantage of being PEDS EM trained. You could still work at a children's hospital in a pediatric ER or in a large tertiary care hospital that has a separate PEDS ER. And you could even work, if you're in a combined, like a big hospital, say like UC Davis, you could work some shifts on the main ER and you can work some shifts in the PEDS ER, and you can get a mix of both. So in terms of job flexibility, you have a little bit more flexibility if you're EM trained. For me, being pediatrics trained, so I'm general PEDS boarded, and then I'm PEDS EM. I could not work in an adult ER. I would need to work in either a separate wing in an adult hospital where they have a pediatric ER. So it's going to generally be a bigger hospital that has enough volume to support a dedicated PEDS ER, or in a standalone children's hospital. That is, they only see kids. The reason I chose pediatrics first is I did not enjoy adult medicine. And I did not want to do an adult ER residency for 3 years. When it comes to in fellowship, the adult ER residents that come into PZM fellowship, they tend to be better at procedures, just because in adult ER, you get way more procedural and trauma experience than in a general peds residency. Whereas in being pediatrics trained, you have a lot more medical knowledge when it comes to medically complex kids. So kids with syndromes, G-tubes, trachs, things like that. So the training in terms of your fellowship, for me, my focus is getting as much trauma and procedural experience during my fellowship, whereas the adult like the ER trained fellows, their focus, they're already procedurally proficient. They tend to be. They're more focusing on getting like that pediatric knowledge and stuff like that. So there's not one way that's, I would say is better than the other. It's really figuring out, do you want to do adult ER as well, or go through adult ER residency versus a peds residency? Yeah, and just having different type of skill set.
Another question is, did you take both the USMLE and COMLEX?
Yeah, so I did. I took both. I took USMLE step 1 and step 2. Once you get into residency, you don't need to take USMLE step 3. I took COMLEX 3. But so if you go to a DO school, you're required to take the COMLEX. It's part of your graduation requirement. You have to take COMLEX 1 and 2. The reason I took USMLE was I was applying at a time there was a lot of uncertainty. We were going through a merger of our graduate medical education system. So I was actually the last year where there was 2 separate matches. So there was a DO match where there were programs that were certified by the American Osteopathic Association, and then the other match, which is the ACGME match, which is the main residency match. And to be really, competitive, especially pediatrics, there's not a lot of DO pediatrics programs. And I was applying to ACGME programs. I really wanted for them to be able to compare apples to apples. There was some programs that were ACGME that understood the COMLEX and were more DO friendly and understood it. But especially I'm Canadian, I needed a visa, I needed anything. So I didn't want another thing, kind of going against me. So I wanted to take the USMLE so I can be compared to my MD counterparts when I'm applying to these residencies. Now there's a single match. And I would say if you're applying for a competitive specialty or a competitive program, it would be, better for you in terms of having more options and being more competitive to take the USMLE. That way you're getting compared if you're applying to, whichever children's hospital or whichever residency, that way they can compare you apples to apples to your MD counterparts. If you're applying to a specialty which is very DO friendly, you're applying to a residency that's vast majority DOs, like the program is DOs, it's more like family med oriented or primary care. And they openly say, like, we don't care about USMLE, and those are the only programs that you're applying to, then I would say that's probably the only reason to only take the COMLEX. The other reason not to take the USMLE is if you think you are not going to pass the USMLE, right? So, hey, I'm not the strongest test taker. The COMLEX is a less challenging of a test, and I know I can pass it, especially USMLE is pass-fail right now. So I would say even more reason to take USMLE because all you have to do is pass. Before, there was the concern of, like, when I took it, like, if you took USMLE but you barely passed, could it look bad against you versus, just doing average or above average on the COMLEX? That might be more helpful. So now with USMLE step 1 being pass fail, I think 100% you should take USMLE. If you're doing your practice test and, hey, I can pass this on my first try, it can only help you. And then in terms of USMLE step 2, most places, by the time you're applying for residency, they'll probably want a step 2 score. So if you're applying somewhere competitive, I would take USMLE step 2 as well.
The other thing is that if you are applying to a residency program that's affiliated with an MD program, you have to take the USMLE.
Yeah,
Even if they say they don't
yeah,
care, you should, just because that's you're being compared with
yeah. And people
apples with apples.
and they're not going to say, places are not going to openly generally say, oh, we're going to hold it against you for not taking it. They'll say like something more politically correct on their website, and in reality it may not be true. So in the end is if you want to be compared against your peers, and you want a spot over somebody else, you got to prove to them that your training is equivalent. And I'm very proud of my training, and the curriculum, like the medical curriculum, it's pretty much the same. They model it on MD schools. Like, in fact, where I go, they have a DO and an MD program now in the same school, and the same teachers teach it, and it's the same classes. So we just take a DO unit there. So you will be well prepared, and you take the test prep resources and things like that, like UWorld, and there's it's in your advantage to take the USMLE. You're holding yourself back and limiting your options if you don't.
How did you do the study for the ComLife and USMLE?
So there's a test bank called UWorld, USMLE World. It's like the best. Everyone takes it. Everyone pays for that and takes does their questions. Then there's like Pathoma, which is a review, which goes over pathology, which is another one. And then you use first aid for USMLE. I use those three resources exclusively. I'm having a test prep background. I've seen way too many people buy every resource that's out there, and they barely get through any of them. So my philosophy always is to pick a few resources and use them thoroughly and use them well. If you have too many items and you're not using them, then it's a waste of money, waste of time, and it's splitting your efforts. So take 2 or 3 resources. The same thing if you're applying to MCAT. Have your test bank, have like a review book of some sort. And maybe you want to supplement it with some sort of video series or something like that, or flashcards, and use like 3, maybe 4 resources max, and use them fully. And so that's the same thing with UWorld, and first aid for USMLE and Pathoma. I just used those, and I just did them front to back multiple times, things like that, and you'll do well.
What about did you what did you do when you were in undergrad to know that medicine is your path?
Yeah, so a lot of it is finding like shadowing opportunities, other opportunities, volunteering. That was the main thing for me, is like volunteering, kind of being exposed to those things, talking with other people that were in the medical field, really, figuring out if this is something for me. So I did a lot of volunteering at UC Davis in their and at Sutter. I at Sutter in their emergency room, and at UC Davis through as a UC Davis student. You can do that. I know there's like there's like that, if you're interested in the surgical field, there's that one you can apply for. Is it still going on, Jubin, the surgical internship?
No.
Okay, so that's not going on anymore, but I think they still have shadowing and things like that, and volunteering, and looking at other fields too. My elder sister's a dentist. I shadowed her in her dental office a couple of days, and I realized like dental is not for me. It's not something I wanted to do. I went to a lot of conferences, and listened to a lot of panelists and things like that, and really, that's kind of the main way I figured it out. I didn't know when I started undergrad that I was going to do medicine. I was actually a poli-sci major my first year, and then I switched and went from there.
What about med school? What are some of the things you did in med school?
Yeah, so I was very active in med school. I did a lot of community service. I was part of like the SNMA association, and I was in student government. So that's really when I found like I hated complaining about things, and I wanted to more work on fixing those things. So instead of complaining about the attendance policy or this policy or that thing, I really wanted to be hands-on and change it myself. So I was actually our class president for our med school class. I was in like other leadership and mentorship programs through there, and it really helped build my resume. It looked really well when I was applying to residencies, that I had all this leadership experience as part of some national leadership associations through being in student government in medical school. And then that helped me get my in residency, becoming a chief resident, and continuing that kind of path and going from there.
This is another one. Can you please talk about the extra components for DO school? Like how much more time of studying is needed? It seems that DO is more difficult than MD because of the extra work.
Yeah, so the extra components are in your first 2 years. You take an additional class, which is called Osteopathic Principles and Practice, or each school might have a different name for it, Osteopathic Principles or something like that. And basically, the difference is DO is also, besides learning, your physiology, chemistry, biology, pathology, anatomy, things like that. They focus on another unit called osteopathic manipulative medicine, which I would liken it similar to like physical therapy and some elements of like chiropractic. And it's more like identifying landmarks, muscular tension, using different techniques to help relieve pain and other like kind of dysfunction. It was for us, it was, I think, 1 hour a week of lecture and 2 hours a week of a lab. So where we were in a lab similar, we actually have a physical therapy school at my school, and we use the same physical therapy lab as the PT students did. And some of my instructors were actually physical therapists, where you learn a lot of these techniques. I, as a pediatric emergency medicine physician, I very rarely use any osteopathic medicine in my practice. Some of my colleagues who are family medicine or physiatry, physical medicine and rehab, they use it actually a lot in terms of for back pain and neck pain and joint pains and things like that. Is it extra work? Yes. In terms of time lag, yeah, that's 3 to 4 hours a week. You're spending more in a classroom. Is the material very difficult? I would say no. And there is some applications to other things, like it helps with anatomy and things like that, because you're spending all this time hands-on. You're getting comfortable like touching your patients and using just identifying landmarks and things like that. When I have a patient come in with knee pain or back pain and things like that, I'm much more comfortable examining them and identifying those landmarks and helping them out, just because I've had so much more hands-on time versus if you just never got that experience. It is extra work. Is everything going to be applicable to your future career choice? Probably not. Like for me, probably 90% of what I learned, I'm not using, but that's because of the field I'm in. And for some people, they'll use it a lot more, and some people might use it 0%. Like, if you're like a general surgeon, you're probably never going to use an osteopathic technique. Yeah, so it's extra work. It's not a crazy amount. It's, again, if you had the option to not have to do the extra things and it's not something that you're interested in and you can get into an MD school, I would choose the MD school. But if you didn't get into into your MD school and this is going to be the best path to get you where you are, then, you go for it. And I see another question. Did you encounter any prejudices or prejudgments from patients or colleagues being a DO versus the MD? So I would think there probably is prejudice and judgments and things like that. I went to medical school in Florida, which there's a lot of DOs in Florida. So it was not as big of a deal because a lot of their primaries and stuff were DOs and stuff. And even in New York, where I'm in Long Island, there's a lot of DOs. I know in California, there might not be as much like DO, although I'm seeing a lot of DOs there now. Is there prejudgments? I would say, yeah. People probably think, hey, this person is a DO because they couldn't get into MD school, right? Just same way, maybe people say, oh, this person went to a Caribbean school. They couldn't get into an American school, things like that. I would imagine people judge, and some people may not judge or not know the difference or care. And some places might. In terms of patients, I don't think any of my patients have ever cared for especially being in an emergency room and things like that. They're happy that a doctor's coming to see them after their 2.5 hour wait.
2.5 hours. What
Yeah.
ER do you work in?
Yeah.
For me, if it's not double digits, it's not a real ER.
Yeah, so we run a pretty efficient ER, like where we try to bring kids back as soon as we can. But yeah, so there's the long waits and stuff like that. They're happy. In terms of colleagues, I've never had a colleague be prejudiced against me, but I've also trained at a place with a lot of DOs and things like that. Do programs have prejudices? I would say there are some programs that have never taken a DO. Is it because DOs never applied there, or DOs weren't competitive to go there? Or is it because there's some sort of bias? Because I have colleagues from from my class who were like insanely smart, scored in the 99th percentile, and they went to like top flight, top 5 programs in their specialties. And then there's other places that have never taken a DO. So I'm like, if you've never taken a DO, maybe there's some sort of prejudice. Yeah, so I would imagine there's prejudices everywhere. Has it been a big deal? Luckily for me, I haven't encountered any major deal or, oh, you're a DO, I don't want to be seen by you, or someone talking down to me or anything because of that.
Yeah, I have a friend of mine that he went to the DO school. Do you know Jason? Anyways, you probably know him.
I know, but Jason, using vascular surgery, right?
No, that's Jason McKelvey. This is his name is anyway. So he went to DO school in Alabama,
Mhm.
and then he got into a really good residency in emergency medicine um in New Jersey, and then now he's Scott Wilder. Scott Wilder,
Yeah,
and he's just got hired at Kaiser in Central Valley.
yeah,
I have I actually know a UCSF emergency medicine resident, which is one of the, and also it's one of the top ones, and she was a DO.
yeah,
So yeah, to be honest with you, I work with DOs too in my
yeah,
where I work at, and nobody really cares. Like, you're went to medical school, you're licensed, you're here.
yeah.
Um,
Once
as
you're attending,
some
nobody cares.
Yeah,
Honestly,
if you're a resident, nobody really cares. They do
yeah,
care if you don't like do your job or show up or are rude to staff and
yeah,
and stuff. But we've never had. I mean,
yeah.
and I even remember when I worked at Davis, one of the residents,
Mm.
they give an award every year to a resident, and this gal, she like won it 2 years in a row, and she was a DO, so it doesn't really matter. I know actually a DO is a neurosurgeon at Davis, and
Yeah.
so
Yeah, you're
um,
at top places like so my program is affiliated with the Children's Hospital of Philadelphia. So I actually go do my pediatric ICU training there. And some of some of the chairs of the departments and things like that are DOs. And Children's Hospital of Philadelphia is a top 5 children's hospital in the world. And I was surprised. I was like, oh wait, you're a DO and you're like running the pediatric cardiac intensive care unit here. Like that's crazy. I didn't realize there was
Yeah, I think if you're a DO and if it's an issue for you, then that's on you, but other people don't. But also I think that
yeah.
other people, if they have an issue, that's on them. It's not on you.
Yeah.
So
And there's going to be
uh
prejudiced people out there always. So
sure.
it's, but it hasn't been a hurdle. It hasn't affected me in terms of limiting my opportunities and things like that. Um, and yeah, I agree with Ruben. It's what you do. It's your actions and how you represent yourself.
Um are California DO schools very difficult to get in? I hear that it's easier to get into DO schools, but not in California.
Well, California
Um
in general is competitive, I would say, anywhere in California.
yeah, I mean, yeah, California DO, MD, PA, undergraduate, even dog catcher school in California is more difficult
Yeah.
um than anywhere else, just because everybody wants to live in California. Quality of, I mean, it's expensive, but quality of life, weather, also family too. I mean, California has 40 some odd million people, so it's the most populous state. So
Yeah.
yeah, I mean,
Yeah.
I read a statistic that for every medical school seat in California, either both MD and DO combined, there is 41 applicants for that one spot. So yeah, so it is competitive, and as much as I would like to say that everybody should apply, but California is a very competitive place, and medical schools in California don't even have to do a lot of recruiting. They
Yeah.
get they get enough applicants for them to to not even, like, if they don't do one recruiting event, they'll be fine.
Yeah.
They'll get
And-
people coming to their schools.
yeah.
But yeah, but it is competitive. Even the DO school is very competitive, like Turo, which is the first DO school in California, and they're in Vallejo. They're very competitive. I mean, their numbers are probably as competitive as some of the second tier MD programs. Uh, even I even know somebody who went to Turo because um, then they got into a medical school in Southern California, and they didn't get anywhere in Northern California, and they applied to DO school even late, and they got into Turo, and the numbers were great. And the only reason was because their spouse was also um, they needed to be close to their spouse and children because they were living in Marin. So it was like, and their spouse had a job there as well. So it just worked for them that, Turo was like the best option compared to an MD program. I think it was,
Yeah.
I don't remember. I think it was UC.
I know some situations like that where they chose a DO school more because of like the geographic preference was more important for them, whether it came to family or other reasons. And I've seen that. Yeah, and generally, if you look at the percentage of medical students like in other states, so I went to a school in Florida. If you look at all the South Florida medical schools, most of them are from Florida. And then if you look at the number 2 state representative, it's California. It's not like the neighboring state. You look at a New York medical school, the majority will be say from New York or New Jersey, and then this it'll be like 30% are from California on like the other side of the country. California is really well represented all around the country, whether it's like Michigan or the South or anywhere. It's so competitive in California, and California has such a really good university system that they produce crazy amount of pre-medical students that are very competitive, and a lot of them have to go out of the state, unfortunately.
Yeah, they do a ranking of how many people apply to medical school from one university. And I think number one is UCLA, number two is Berkeley, number three is San Diego, number four is Davis, and then number five, like Ohio State, or
Yeah,
and
yeah.
Michigan, and
Like if you did a top 20, probably like 15 would probably be from
yeah.
California.
Probably not 15, but
Yeah.
probably it's like top half of it is from,
Yeah.
yeah, to California. And then the other thing is California also has people from other states that want to come here too. So,
Yeah, it's a
um,
desirable place to be. So in terms of the competitiveness of DO schools, so it depends on the school. I would say if you're thinking of applying DO, your preference should be to go for one of the more established DO schools that's been around for a while. They've graduated multiple classes, and they have strong linkages with rotations and teaching things and going through there. There's a lot of new schools out there, and some are branches of established schools, but still, I think anytime you're part of a brand new program, there's like a learning process and a building process and establishment process. And if it's a brand new school and they haven't demonstrated, like they haven't graduated a single class yet, they don't even know what hurdles they still have yet to face. We don't know how well they supported the students in their application process, the quality of rotations, the quality of students they were able to produce. So if you go for the established DO school that's been around for 30 years and has an established track record and alumni network and mentorship and all those things, it would be better. And those tend to be the more competitive ones, the ones that's been around for a long year. And then if you only option is you're only getting into one of the newer schools, I would go to one of those that are linked. It's at least a branch campus of one of those established schools, because at least you get some of those resources from the established school, or have the ability to do rotations at sites from their main site and things like that. And then only, like if it's a brand new school that's not affiliated with an established school and they don't have a track record, I would put that at the bottom of my list, because you just don't know what you're going to get. And that's probably where that's going to be your terms of competitiveness. Like the more established ones are going to be more competitive, and then the brand new one, it's going to be not as competitive. Even I think that happened in California with North State, the MD school. The first 2 years, no one knew what they were going to get, and it wasn't crazy competitive. And now they've demonstrated they've actually done really well in placing and things like that. It's become very, very competitive.
the question is, in the application process, um, the DO schools different from MD schools?
Yeah, so the schools use a centralized application service. So the MD schools have their own centralized application service, and the DO schools have a separate one. And then the state of Texas has their own application system, where both the MD and DO schools are in one application system, and it's run by the state of Texas. Texas is like a 90% in-state, like mandated by law. I think they have to take in-state. So Texas schools are generally very competitive. So unless for some reason you had links to Texas or very, very strong desire, I would probably avoid the ones in I wouldn't apply in the third application system for Texas. So there's like AA Comas. I see you put the links there in the chat. Is the one for DO schools. And then I think it's AMCAS is the one for MD schools. It's nice because it's a centralized repository. You write your personal statement, your letters of recommendation get sent to that single repository, your transcripts, everything. So you send it to each of those application services. In your DO school one, I would probably change your personal statement a little bit, at least add a paragraph about why specifically DO. And a lot of DO schools prefer, or some even require, that you have a letter of recommendation from a DO. So if you want to tailor your application for your DO schools, I would modify your personal statement to add some things about why DO, and if possible, get a letter recommendation from a DO.
Yeah, that one is probably the you have to shadow, and they have to write you a letter of recommendation. I just put the links on how to find DOs. There's actually 3 websites that you can find DOs to shadow. One of them is California. So the first one, you have to be a California person to do that because it's only the California osteopathic schools, and then the other two are national, and you can put your zip code and find people to shadow there. And yeah, that's the big difference. But the application, as a matter of fact, if you look at it, they're very similar from AMCAS, same information, everything else, and they're not backward compatible, so you can't like download and upload one to the other. But also make sure that you write about, why you want to do DO. I think that's the big one. Don't say that I've always wanted to be an MD all my life. Probably not gonna end too well for you. But yeah, but it's the same concept. It's just that ask you. The other thing is for Texas though, is if you have like a reason to be in Texas, like let's say your spouse is in the military or you're in the military, that you need to be close to San Antonio or any of that stuff for medical school, then
Yeah.
you could do that. And I know
You're going to want to show links to Texas or have a strong reason for Texas. The Texas schools are all great. Even the DO school is very subsidized by the state. So like their schools are a lot cheaper in terms of tuition costs, and they're all very high quality schools in Texas. And it's a lot cheaper. So they're very, very good schools. Some of my colleagues trained at the schools in Texas, and it's amazing training there, but it's very competitive if you're not from Texas, especially.
oh yeah, the legislators would come down, like California too. The legislator came down tough on them. But some states like Arkansas, like you absolutely like have to be an Arkansas resident, or like, so that those are just because those are the restrictions, because they pay for the medical
Yeah.
school. So
And they want
even
people
though,
to stay there and practice there, and you're more likely to stay and practice there if you're from there.
yeah, yeah, so it's just a really hard thing. Um, any other questions you guys have? This is your chance to ask away. So can you tell them what you talked a little bit about them? So as a pediatric emergency physician, what's the difference between a pediatrician, a pediatric intensivist, and then the regular ER doctor?
Yeah. So a regular ER doctor, generally, they're seeing mostly adults. At a community hospital, you might see kids of all ages and things like that. So I'm becoming an emergency medicine kind of physician in that the ER is like, you never know what's going to come in. You get a kid, or a patient in, and they have they slam their fingers into a door, or they twisted their ankle, or they just need some stitches, versus they can come into cardiac arrest, or they got, hit by a truck and, it's a trauma alert and things like that. So, or a gunshot wound or anything like that. So you see the wide spectrum of everything to just like belly pains and shortness of breath and things like that. So in the ER, we say we're like we're like a master of none, and just like you're just kind of MacGyvering and doing kind of like, you're in the trenches and you just do a little bit of everything. So I'm a cardiologist, I'm a pulmonologist, I'm a nephrologist, but like in a very small snippet of what are the things that are going to kill this person right now, type of thing. And my job is, when you walk into the ER, is to determine, can I fix you up and send you home? Do I need to do more investigation and admit you so you get further workup, or do I need to do something right now or you're going to die? And that's like our triage system. Like, this kid, I need to go see them right now. And this kid is going to unfortunately wait 3 hours before I get to them because they have a lower acuity condition and it can wait, and they're going to go home after this. And determining that. In terms of your level of training, so if you're pediatric intensive care, you're taking care of admitted patients in a pediatric ICU setting. So it's very different. It's not like ER, you don't have much continuity of care. I'm admitting them or I'm sending them home. You're not spending more than maybe they're staying in your department a few hours. Maybe 10 hours, 12 hours max if someone is going to stay in my department before they're up in a room or back home. In the intensive care, you might be taking care of patients for weeks and things like that. You might be dealing with, in pediatrics, a lot of kids with chronic issues. These are very medically vulnerable population that we deal with, and they probably make up the vast majority of our ICU patients. Even like a RSV virus can make one of these kids, being on a ventilator and things like that for weeks, and dealing with a lot of those. So for me, I love the critical care aspect in terms of this person is very ill and I need to intervene right now to save their life. But the ICU is very mentally taxing because you're dealing with a lot of ethical things of like, am I prolonging this person's life? Am I doing things to them or am I doing things for them? And dealing with that, a lot of continuity of care, and it's very difficult, very challenging. And the ER is a little bit more fast paced and a little bit less continuity, and it's more for me, it was easier to recover mentally from I have a bad case and you take, a minute breather and then you move on to the next thing and you just go through. And the ER, you have to handle like 20 different things at once. You have like this patient's getting worked up, this, and you kind of have this ADHD type of personality and you're moving from patient to patient and task to task. And that suited me well. And so, yeah, I would say
they don't let you up on the floors after you're done, right?
Well, I'm a general pediatrician, so I could work as an inpatient hospitalist or something like that. I can moonlight in general peds, but yeah, in the general, like in my career as an ER physician, as a pediatric ER physician, I'm going to stay in an ER. I don't want to do inpatient. Yeah.
They won't let you in the hospital.
Yeah, they let me only in the ER, basically.
But yeah, talk about a little bit about your personality and your specialty, because and talk about like why is that so important?
Yeah, so you'll see, and generally, like it's like you see all these memes or these parody things, and the people that are in those specialties, they rarely get offended because it's so true. People have different like very distinct personalities, and there's always exceptions and things like that. You'll find the grumpy pediatrician, or you're like, how is this person a pediatrician? So pediatricians, we're supposed to be this like bubbly, very happy, very smiley, sometimes immature type of people, like where we just like, you see a baby and you're like, oh my gosh, you're so cute. Like you just do that. So that's your pediatric personality. And then the ER is like ADHD. So I would say I'm like that happy person that has ADHD. And so that's why I'm like pediatric ER person. The ER physician is just like, they get bored very easily and they need constant stimulation and constant different things happening. You need to like to be under stress. If you're somebody who if you're very thoughtful and you really need to think things through and you want to think of the pathophysiology and the fluid balances and do all these calculations and things like that, you're going to be more like a neurologist or a hospitalist or something, or a nephrologist or something like that, where you really enjoy the pathophys and you really want to figure out what's kind of going on, where the ER person is just like, okay, are you dying right now? No. Okay. This, you just kind of Western, like you're just like cowboy medicine type of thing. Surgeons, it depends. Like the ortho people, we think of all as these like gym bros and stuff. Like obviously there's exceptions and things to that, but they just love being in the operating room and doing their, reductions and things like that, versus like other type of surgeons have like very different other personalities, and the plastic surgeons all think like they have the hand of God and things like that. So there's like all these different personalities, and you really got to figure out which personality you have, which area of medicine suits you, and seeing which one, like if you suit a thing, you're going to be very well at it. You really enjoy it. You're going to excel in that type of career or that field.
Um, yeah, no, that's a really important thing to look, and that's why like your third and fourth year of medical school is so important. But also, I think it's also important to know yourself because
Mm.
um, I know people that went into ER, for example, and they were miserable and they actually ended up leaving. Same thing with surgery. And so
Yeah.
um, the question is elaborate about the extra components of DO training can benefit someone that wants to go into family or internal medicine.
Yeah. So with the DO training, you learn like the osteopathic manipulative medicine. For me, again, there's like many aspects to it. For me, the only part that I felt was like very useful and practical and has more evidence-based like proof to it is the musculoskeletal parts of it, where you do, soft tissue and muscular kind of maneuvers to help alleviate like acute pain or help with mobility and things like that. So for me, if you're, say, a family medicine outpatient physician and you have a patient with chronic back pain or chronic shoulder pain or something like that, and say they have kidney dysfunction, so they can't take ibuprofen or NSAIDs and things like that, or other issues, and you're trying to wean them off of opioids or other things like that and pain medicines. This is a thing, that you can use along with physical therapy. You use your osteopathic manipulative techniques and you can help your patient. If especially if you're doing physiatry, physical medicine rehab, family medicine, like outpatient, general practice, I think it can be very useful. Also helping with diagnosis and things like that. Just really, okay, I feel some like instability in your knee and things like that. Okay, let's send you to ortho for MRIs. You might have a ligament tear or something like that. Just getting those type of aspects. I think that's probably the most practical use of osteopathic medicine, is more in the primary care outpatient type of fields. Yeah.
Yeah, the other thing is you just have to understand the history of how osteopathic medicine started and where it was where it was um, where it headed, but ultimately it was done by these people that literally were like the only doctor in the 300-mile radius, and you were basically doing everything.
Yeah.
And that's how basically osteopathic medicine
Yeah.
started.
It started
And
also when MD was not really evidence-based medicine, when they were using leeches and stuff like that. And then they did kind of something similar to, I would say, like chiropractic. And then eventually they realized, okay, this can't cure everything. And they started learning as evidence-based medicine came through, it kind of merged towards. And I'd say that currently how osteopathic medicine is, it's not very different from MD. It used to be like, oh, DOs look at the whole picture and it's holistic, and we treat the mind and the body and all this stuff. But if you look at how medicine has evolved, MD training is also very holistic. I think in every the future right now, or every medical school and everything is focusing on the mental, the physical, and how they react, and looking at the patient as a whole, and looking at their socioeconomic factors that are affecting their health, and looking at the big picture and putting it all together versus just looking at one component. So I think, it used to be probably very different, and it was, but now the lines are really blurring.
yeah, the other thing is, I mean, the whole thing it was started by a guy named Andrew Steele, and it was in rural Missouri. That's in the 1800s, in the mid 1800s. So
Yeah.
that's kind of how osteopathic medicine started. Somebody has a question: was how is um,
How's it different
osteopathic
than?
medicine than PT?
Yeah. So osteopathic medicine, you're a physician. So you're, you're learning pathophysiology, anatomy, and physiology and all this stuff to treat medical complaints. Physical therapy school is focused more on anatomy and functional like physiology and just doing more physical therapy, whereas DO school, the main focus is still medicine. So you're learning pharmacology and pathophys and stuff like that, and you're going to treat people. Like a physical therapist can't treat, diabetes and prescribe medicines and do other things like that.
Yes,
It's
physical therapists cannot diagnose. They cannot they could create their own treatment plan. They cannot write prescriptions.
yeah.
They cannot help you with your sore throat or suture you back up in pieces if you they can't suture you, they can't intubate.
Yeah.
They're not physicians. And
Yeah.
so
And if you go to geo school, you go to residency afterwards, and you go into whatever specialty that that your focus is. You can become a surgeon or a neurosurgeon or a primary care doctor or something like that. So it's very, very, very different. Yeah, I would say in that aspect.
the other questions, do DOs do the exact residency as MDs altogether or separately?
Yeah, so there's a single graduate medical education system. So all residencies are all accredited under the ACGME, and DOs and MDs both apply to the same residencies, and they do residencies together. Some programs might have a majority of DOs, some might have a mix and a minority of DOs, and some might only have MDs in there and not have a single DO in the program. But it's the same application system, and you go through the same match. It's all at the same time, and you go into the same programs. Yeah. So like in my fellowship, there's half of us are DOs and half are MDs. Happened to be, and when I did my chief year, there was maybe 3 of us that were DOs, and 80% or like 90% of them were MDs. So it just depends on the program and how many MDs and DOs are in there, but it's all together, same training, and you're eligible. Like I take the same, I'm board certified in the by the American Board of Pediatrics, which is the same board for everyone, and there's no distinction in terms of that. Some states, when you get licensed, might have a different licensing board, and that's just the state agency into which you submit your paperwork, and they issue a license. So it's not
It's just who you pay your money to. That's all it is.
In New York, it's all combined. So I'm licensed in the state of New York, and it's all one board. I think California might have 2 separate boards, but there's no difference. Yeah. In terms of licensing. Yeah. If a major trauma patient arrives with the same assessment. So you'll learn that when you go to medical school or something like that. It's ABCs, airway, breathing, circulation, and it's any trauma type of thing. And I'm not going to delve into the nuances of that and what to do, but yeah, you learn these things. Everything is kind of standardized approach, and especially in the ER and trauma world, because it's such an intense situation. You need to have a standardized, uniform approach, and so the doctor here versus the doctor in California versus the doctor in New Mexico, we all should approach a trauma or a difficult situation in kind of the same organized, systematic approach. And that's how trauma, and we have to get training. You get certified in trauma by the American College of Thoracic Surgeons, actually, of trauma surgeons, where you get ATLS certified. It's just like how people get basic life support certified, or advanced life support, as an ER, and all ER physicians and trauma surgeons have to get American trauma certified, so ATLS certified. So and you learn all that then.
Any other questions? Anyone?
No. Well,
What
Um,
was, that's another question. What was the hardest part of medical school?
So I'll tell you this, medical school, the material itself is actually not very hard compared to undergrad. So like when you take a biochem course in undergrad, you have to learn every little thing about biochemistry. In medical school, it's just kind of like the highlights of it or the big, the rate limiting step. You don't have to learn the entire cycle. You just need to learn the three important components of the cycle or something like that. The issue with medical school is volume and pace. So the hardest thing is covering like what you covered in a semester in college, you're covering in like a week or 2 weeks in medical school and just learning the highlights of it. So I think that's the hardest thing is time management and managing the volume and the pace of how medical school works. The material itself, not as difficult. It's more volume and pace. And so that was the hardest part is learning you have to kind of relearn how to study and adjust to a different pace and a system in medical school. Everyone says it's like drinking from a fire hydrant. And I would, somewhat agree with that assessment is just, there's so much coming at you and you trying to absorb as much as you can. And just managing your time and getting that balance, still being able to go to the gym and cook and have a social life and doing all that while managing your time effectively. And that was the biggest challenge.
What about residency? What was the hardest part?
Oh, residency is just physically so brutal and taxing. Like, especially like when I was a peds resident, we had to do like 24-hour calls like every fourth night. So just being able to function at 2 a.m. It takes some time and transitioning to actually taking care of patients and having responsibility. So at 2 a.m., I can't make a mistake. There's a lot of responsibility on you right now. This is someone's child, and I got to calculate their, it's very prone to making medical errors and things like that when you're tired and things like that. So that was the hardest part for me is having the pressure of like actually taking care of patients. Whereas when you're a medical student, you're a little bit protected. There's someone else that's, kind of doing everything. You still have an attending when you're a resident. And then I think when you finish residency and you're attending and there's not an attending, there's no other attending looking over your shoulder now. That's probably, has its own set of fears. But as a resident too, you're doing a lot of stuff. You get a lot of autonomy in residency. So that responsibility, it's tough.
All right. Well, I don't have any more questions. If you guys don't have any questions, I just worked last night. I'm gonna go.
Wow.
And you have the weekend off, so lucky you.
Yeah.
Thank you. Okay.
Yeah.
You're welcome.
Yeah, no, it was great talking to you guys. Like I said, when I was in your guys' situation, things like this helped me a lot, kind of figuring out what I wanted to do with my life. I know it can be scary, right? There's like all these paths, there's all these steps. It's competitive, it's difficult, and things like that. The first job for you is figuring out how bad do I want this? What do I want to do? What am I well suited to do? What field am I willing to put in the time and the effort and really go towards? And it's okay if it's just not something you're willing to do. You're like, hey, I have other goals in my life, or this is way too long and I need to be, maybe, PA school or a different field is better for you in terms of the time, effort, or the lifestyle you want to live, or the balance that you need in your life. So just being honest with yourself, because the people that I've seen that have gone kind of halfway and not made it all the way through is because they were doing it for the wrong reasons, or they just felt like they had to do it because they initially thought of doing it and they didn't want to seem like a quitter. But really do some soul searching, figuring out what field do I really want to do? What am I going to be suited for? What's going to make me happy in life? And once you know that, then you build a plan and you put in the work and you go there. But the hardest part is figuring out where is my destination. And then the journey is, if you really want it, you'll get there. But It's really figuring out how badly do I want this destination? Is this the right destination for me? All right. All right, guys.
Very cool.
Yeah.